So I'm going to present a case report on acute kidney injury, named by case report as the Great Impersonator, and you will come to know about why I have named in such a way with the clinical findings and the history provided. Going to the presentation. So our patient is a 36 years old female, attended with complaints of easy fatiguability for the past 1 week and abdominal pain on and off for the past 1 week. And the abdominal pain was diffuse in nature. It was not radiating, and there was no specific character like colicky like that. The patient was initially admitted in the surgical side. So the surgeons took CT and ultrasound to rule out the acute cause of surgery like cystitis, pancreatitis, intestinal perforation, gastritis, UGI bleed. And there was no surgical causes pertaining to the abdominal pain history. And the routine investigations came. The routine investigations are displayed in the slide. And the patient had a total count of 3,400, HB of 7.5, platelet count of 1.1 lakh, urea of 45, creat 2.5. Serum amylase and lipase levels are normal. And the patient had a hyperbilirubinemia with a total bilirubin of 3.5. SG40PT levels are normal. Alkaline phosphatase levels are normal. Then the urine routine analysis done in the initial time came as normal with no deposits, no RBCs, no pus cells, and no proteinuria or even trace. And the ultrasound abdomen and CT abdomen done were normal. So the patient was in medical side. So we have plethora of symptoms, which is displayed in the slide as the patient had abdominal pain, and reports done revealed acute kidney injury, and the patient had a drop in hemoglobin along with the hyperbilirubinemia, suggesting it may hemolysis may be present in this patient, and the patient had pancytopenia with total count of 4,000 and HB of 7 and a platelet count of 1.1 lakh. So the investigations done were CT, ultrasound, amylase lipase for abdominal pain, and we did a C3, C4 urine analysis, serum CPK and ANA to rule out the causes for acute kidney injury. And for the hemolysis picture, we'd asked the residents to send the serum LDH levels and ANA. And for pancytopenia, we initially had the thought of doing a bone marrow biopsy for this patient. And these were the initial reports. The initial reports didn't reveal anything. The peripheral smears showed a normocytic normochromic anemia with no evidence of hemolysis. We did peripheral smear twice in this patient, and in both times there were no evidence of hemolysis or no histiocytes present in this patient. And we repeated serum LDH daily, and the LDH level was never crossing over 200. And serum D dimer was less than 0.5, and we did direct Coombs test to detect any autoimmune hemolytic anemia in this patient, which turned out to be negative. And the ANA report came, it came as negative, and the corrected reticular gain was less than 2. So now we have a plethora of symptoms: acute kidney injury, abdominal pain, hemolysis, and pancytopenia. And the initial investigations and the second line investigations like ANA, serum LDH, and peripheral smear didn't give us any clue. So now we had two options: to poke a needle either into the bone marrow or into the kidney to look for the tissue biopsy and analysis, which will reveal further diagnosis in this patient. So we had a set of differential diagnoses based on the patient's conditions as of now. So first, the primary diagnosis we had was any infection causing a thrombocytopenia with acute kidney injury, including tropical infections, or SLE. Since the patient is a woman of a childbearing age group, any RPZN with hemolysis, or drugs causing acute interstitial nephritis with the drug causing thrombocytopenia, or it may be TMA causing acute kidney injury along with thrombocytopenia and hemolytic picture, or it can be heme pigment nephropathy causing hemolysis, which in turn causes acute kidney injury with the drop in hemoglobin. And we had other IDs like renal vein thrombosis, since the renal vein thrombosis can cause acute kidney injury, and it can also cause hematuria and drop in hemoglobin in these patients. So we initially had a doubt where to poke. Since the patient had a progressive rise in creatinine, the patient had an initial creatinine of 2.5 at the time of admission. Then the creatinine raised to up to 6.2. So we started the patient on a session of hemodialysis. Then we proceeded for a renal biopsy in this patient. So up to this time, we had only an idea of whether this could be any of these things. We ruled out SLE and TMA, and we had infections, drugs, but the patient had no obvious history of any drug intake. So we had the only DDs were infection and heme pigment nephropathy. And the biopsy report came as, so these are the biopsy reports. As you can see, the second slide, it clearly mentions as pigment cast. So this is the picture. The second picture is the one with the hemoglobin staining, showing heme pigment nephropathy, and the previous slide showed ATN. And this blue color picture is the Persian blue stain, signifying iron deposition in the proximal columnar tubule. And the report came as renal hemocirrhosis, query intravascular hemolysis in this patient. So we went into the literature. Renal cirrhosis, hemocirrhosis is due to chronic accumulation of free hemoglobin in the proximal columnar tubule, which when stained with Persian blue gives a certain color. And there are various causes of renal hemocirrhosis like mitral valve repair, in which there is a chronic intravascular hemolysis, or there may be chronic infection in a tropical area resulting in chronic intravascular hemolysis resulting in renal hemocirrhosis, or it can be a rare case. It can be a case of paroxysmal nocturnal hemoglobinuria causing a chronic intravascular hemolysis, which can result in the deposition of hemosiderin. This is the literature we went upon. There were reports due to secondary mitral valve repair. So we did we went again, we went to the literature and we studied reports of heme pigment nephropathy from southern India, from North India, and from US on paper. In all the three papers, we went over the causes. I will show it in the last slide actually. In the papers from India, they showed infections, drugs, and in the last part, PNH is a cause of heme pigment nephropathy. And in the papers from US and Europe, the first diagnosis was due to autoimmune hemolytic anemia, and the next was due to drugs, and the third or fourth common cause was PNH. So we thought PNH could be a likely diagnosis in this patient, but we have to think many times before sending the analysis because it was around costing around 6 to 7,000 for this patient. So I discussed with the hematologist. Since the patient was having active hemolysis, even though it didn't reveal in the peripheral smear LDH, we did FLAR assay in this patient, and the FLAR revealed CD157 deficient in monocytes and neutrophils. Usually, when we send flow cytometry in these patients, the labs will, or we have to request the labs to do on monocytes and neutrophils. Since there is active hemolysis, we can't find deficient CD factors in RBCs. So the report came as more than 60% of clones deficient in CD157, pointing towards a diagnosis of paroxysmal nocturnal hemoglobinuria. So this patient was having paroxysmal nocturnal hemoglobinuria with acute kidney injury, and the patient might be having the disease for at least more than 5 to 10 years based on the long-term deposition of hemosiderin in these patients. So now paroxysmal nocturnal hemoglobinuria can present as classical paroxysmal nocturnal hemoglobinuria with bone marrow disorders or a subclinical paroxysmal nocturnal hemoglobinuria. So what is termed as a classical one is classical PNH is the one that presents with hemolysis. So the initial test of diagnosis for a patient with PNH with hemolysis, they can straight away go to a flow cytometry. And if the patient is having any additional bone marrow disorder with suspecting means, the initial set of investigation, it will be likely to go for a bone marrow biopsy, since it will alongside reveal aplastic anemia or MDS in these patients. And these are the symptoms. The PNH can present as aplastic anemia, MDS, or a classical PNH or subclinical PNH. And these are the symptoms it can present as. The clinical manifestations will be a hemolytic anemia, bone marrow failure, thrombosis, hemoglobinuria. And the subjective symptoms are fatigue, lethargy, abdominal pain, and dyspnea, chest pain, odinophagia. And in male patients, erectile dysfunction will be present in these patients, and headache will be present in these patients. And when I discussed with one of my hematologist friends, what he told is any patient with a chronic fatigue, the notifying towards a hemolytic anemia, DCT negative, they will usually go on to test PNH because more than 30 to 40% of patients present only with complete fatigue alone. So these symptoms, when I go into the literature, there are many literatures based on PNH findings from the early time to the recent one. And in the recent literature, they have termed the PNH as the great impersonator because it can present in any of the symptoms. So why no evidence of active hemolysis? Since it's termed as paroxysmal nocturnal hemoglobinuria, it can occur anytime. So what we thought is a patient might had a hemolysis before the time of admission, or in the time of admission, the patient was admitted over a period of 7 to 10 days. We did biopsy after 10 days actually. So the patient might have had an episode and might have now noticed it. Even when we did urine routine analysis, it didn't turn out in this test. So why abdominal pain actually? So when there is increased hemolysis occurring in these patients, increase the amount of free hemoglobin will be available, and this free hemoglobin will scavenge actually nitric oxide. So when there is a deficient nitric oxide, it will cause smooth muscle dystonia, and this smooth muscle dystonia can cause abdominal pain. So this is one of the presenting complaint, and the erectile dysfunction in the male patients is also due to deficient nitric oxide. And this is a case report. Abdominal pain in combination with an unexplained hemolytic anemia are crucial signs to test for paroxysmal nocturnal hematuria. There are many similar case reports, isolated cases are presented. These are the two papers which I just read. One is from Renopath actually. The first one, the most common cause of hemolysis is always an infection, then drug induced, and the last one is PNH. And the next one is from Europe actually. And the most common cause is autoimmune hemolytic anemia, and then drugs, paroxysmal nocturnal hemoglobinuria, and any transfusion of incompatible units are due to a hemoglobinopathy. So actually, we did only one session of dialysis for this patient. We give adequate hydration for this patient. We started the patient on steroids, 1 mg per kg, and we tapered over a period of 4 to 6 weeks. And the patient was discharged at a create of actually 1.2. The discharge rate, and the patient is on regular follow-up. We started the patient only on steroids and aspirin, and then now the patient is only taking aspirin. And we have presented the case in ISN Con Southern Chapter last year, and it was selected as one of the best posters actually. And thank you all for this opportunity. Thank you.